Francis was talking about, one of the docs out of JSC, and we're looking to the future to plan medical operations for hopefully a return mission to the moon, or even beyond that as an exploratory class mission to Mars. And we're looking at the kind of technologies we need to develop in order to support that operation. And so what I was going to tell you about briefly today was a little bit of what we're doing for contingency planning in case of a medical contingency, and then what we were doing to support operations, as was discussed by the last speaker, of if we have a contained life support system like sitting on the Martian surface, how can we plan medical support for that? And so the first project I want to tell you about was our KC-135. Have you heard about the KC-135 yet? Okay. Could somebody tell you a little bit about how that whole thing works?
Vomit comments all around.
What's that?
Vomit comment part.
Yeah, I was going to get into the vomit comment. You just kind of stole my thunder there, but this was a team that was required to do the study that we were that I'm going to tell you about. And just to let you know, these studies are very difficult to really bring off, especially at the big agencies like NASA, and it requires a big team of people to support that kind of operation. And so this is the flight pattern that is required in order to induce microgravity. So first you're talking 45 degrees up, and during this phase, during the pull-up phase, you're actually at hypergravity, you're at 2G, and there's a little G monitor that tells you when you change over from the 2G phase. Once you get an altitude somewhere around 45,000 feet, then the vehicle will turn over and head back down again, somewhat like a roller coaster. And this is during the 45-degree inclined descent phase is when you experience the microgravity. Basically what you are is in free fall, but it comes out of the G meter to be equivalent to zero gravity. And you can imagine doing this over and over, you know, that 40 parabolas, what we call parabolas, this type of flight, that some people may have a little bit of motion sickness, hence the name vomit comet. If you ever go in the KC-135, as soon as you walk in, you're kind of hit with that odor of vomit, because hundreds of people over the years, you know, vomiting, even though they clean it up each time, they just can't quite get rid of that persistent. So some people can't even walk in the KC without getting sick to their stomach. And then just let you know, here I'm going to show you a videotape just to describe what I'm going to show you in the videotape. This is the setup that we had. You can see this is our photographer that was doing a lot of the imaging. We also had a hard-mounted camera on the vehicle, and we were downlinking images from the vehicle to a ground workstation where we had some other technical advisors. In this case, an anesthesiologist was advising us about we were doing this on an animal model, a swine model, and so he was advising us on the proper anesthesia to keep the animal properly anesthetized during the procedure. And the whole idea here is to see how well we could function in this kind of telemedicine environment and actually relay data from the vehicle on board and have the interpretation by the ground team and then relay back instructions on how to manage it. And in addition, a goal of ours was to assess the ability to take care of a problem that could very well happen in space. And the last speaker, I'm sorry, Mr. McKenzie, is that right?
Yes.
Was discussing potential prolonged microgravity, and depending on the type of vehicle that's used to get to Mars, that could be an extended period of time, maybe 6 to 8 months. Now, it just so happens at JSC they're working on another type of propulsion system that's an ion drive, a plasma drive system. It uses a magnetic field as a rocket cone, and it may get you there much faster. At least the prototype and the projections are to get you there in 3 months. The question is, could we develop that technology in time to support our first mission? And that's a big question yet. So if we're talking about conventional rocketry on a typical conjunction trajectory, probably in the order of 6 to 8 months as a single one-way period. And during that microgravity period, the bones that the crew members will have tend to lose mineral. Just like as elderly folks, as they age in their activity lessons, they lose mineral in their bones, they become more risk for fractures. The same is true of crew members who are exposed to prolonged microgravity. And in this case, the calcium, one of the minerals in the bone, has to go somewhere. And where does it end up going? Well, it ends up going out in the urine. And as you know, one of the big components of what's called kidney stones, urinary calculi, is calcium. And so it greatly increases the risk of having a calcium-containing kidney stone or urinary calculus in the urine during flight. And in fact, it's already happened on the Mir. This event has occurred, and some of our crew members have had this event post-flight. And for that reason, it's an important medical consideration. We have to have planning. And so part of this study was to look at what the potential needs are of treating a calculus in space and doing endoscopic surgery in microgravity. So that was a technology that's never been proving. There was some of the equipment we have to support this operation. You can see some video equipment there to provide endoscopic views. And there was a little endoscopic screen. So we did this all using camera systems, not actually having to look through scopes. And this is just a picture from later on where we're doing cardiopulmonary resuscitation techniques. And you can see in microgravity, it's much easier to get the type of force vector that you need by turning upside down and placing your feet on the ceiling and using that as a means of doing CPR. So let's just go to this first video and we'll talk about that. And if we have time, we'll spend a little time looking at the Lunar Mars Life Support Test Program. Okay, so this is, you can see here, this is the flight engineer, and he happens to be in the way of our camera. You see with microgravity here, now this guy's floating around. This person is acting through the anesthesiologist. He has a headset on, communicating with them. And in microgravity, it's tough to mix fluids. There's not a good separation, air fluid interface. And you can see here, he's trying to mix some medications to give to keep our subject anesthetized. You can see in microgravity there's a real propensity for fluid to float away. And that was a big concern of the flight engineer about getting that fluid into the electronic systems and shorting them out. And we had to really work hard to try to keep that from happening. And so one of the ways you can try and separate the air and the fluid during microgravity is to spin it around, use centrifugal force, and that's what's often used to do that separation. So you can see here, this is a microgravity phase where we're monitoring. You can see him doing that. He's doing this sort of thing to try and separate the air-fluid interface so he doesn't inject any air into the system. And then you'll see we'll go into a 2G phase. Now this is the ground work support, and so they're communicating via the comm system. And what we have to do during shuttle operations, and we have a DSO where we prove this sort of technology in what's called DSO 334, where we had a ground workstation, a telemedicine monitoring team, and then we used a telemedicine instrumentation pack on board the shuttle to communicate. We had to use the TDRS satellite to relay the images, the video signals, and other signals. Let me turn the sound on. I'm not sure quite how to do that. I should have asked him before he left. Let's see. Yeah. That should be the only sound that we're going to have to worry about, actually. And so we have a little bit of delay in time between doing the relay from the aircraft to the ground, especially if it's in the shuttle. You can see here in microgravity we're doing the procedure operating without the stability that's afforded by being in microgravity, and the appearance of the tissues inside as we're doing endoscopic surgery is very different than what we see in one gravity. And so here we're looking in the bladder, and in this case this is the orifice, the opening of the urine tube coming into the bladder, and now we're putting a guide wire into that orifice to pass it up into the kidney in order to pass a stent. And this would be used in the case that we had a stone blocking the urine tube. We could bypass the blockage with a stent, and that way relieve the pain and the obstruction that's caused by having the stone in the urine tube. And so this is just trying to show some of the operation as it was occurring. This is me, obviously, if you haven't recognized me already, and this is some of the rest of our team. Next to me is so he's doing the ultrasound that's monitoring the placement of the stent in the kidney. This is the camera where we're looking to see those images you were seeing. Those are the images that were downlinked to the workstation on the ground, and also the same images that we see here. And then the assistant next to me was helping with the placement of the guide wires. And you would need a team of 3 crew members on board to really do this operation well. And this is showing some ultrasound. We used 2 different ultrasound units in the study. This particular day we were using the BioSound unit, which has been flight certified and flown in the shuttle already. And also we have, we used an ultrasound that's planned for International Space Station operations. That's called an ATL. That's the company that makes it. It's got an HDI 3000. We're actually upgraded to the HDI 5000 for use on the International Space Station. And that ultrasound device gives extremely good images and has a high versatility and capability for use in flight. Now, you'll see in a minute some of the ultrasound images that we've been able to acquire. There's the onboard ultrasound image, what we were seeing using the BioSound unit. And you'll see here in a minute some of the downlink images that were obtained using the HRF Research Facility Ultrasound, the HTL HDI 5000. And the ATL unit provides, you'll see, very nice images. This is the kidney here, and this is the collecting system of the kidney. And we're showing there's a guide wire in place, that little echogenic area there. There's a guide wire in place during the study. And that's how we knew we were in the proper position in the kidney, and then we would pass the stent in the right location. And then that's confirmatory that we have good position, because we don't have the patient open to do this, and we don't have fluoroscopy, X-ray imaging, in order to confirm that. So we're doing that with ultrasound. Here's another image of the kidney. You can see here, this is the actual stent itself going into the kidney. So, and these are the images that were downlinked to the ground from the aircraft. So let's stop that. So any questions about what we were doing with our KC-135 project? Because I was going to tell you a little bit about our Mars Life Support Test project at that time. How are we doing, Francis? Is someone else that needed to speak?
Did Mario Grace come in? Marlo Grace. Are you? Is she scheduled to speak last? So why don't you finish
I'll
about
finish up.
5 minutes and then
Just 5 minutes here, and we'll go over this real quickly. We needed to support the crew that was inside the Lunar Mars Life Support test chamber, which is a completely closed system now. We did a 90-day study with the crew members, and they had a number of things we wanted to test, one of which is how, when you're in a contained environment under stress like they were, does it affect your immune system? So we did some immune response testing while they were in the chamber. We found out that they were relatively anergic. In other words, their immune system was depressed while they were in the chamber. It was normal before they went in. It was depressed while they were in, and then it returned back to normal once they got out of the chamber. So that's very interesting. We've seen a similar sort of thing during spaceflight. We didn't know if it was microgravity or if it was just their closed environment and the stress associated with spaceflight. And so this is a very important study for us to learn these things. The other thing is that there was contingencies, there was injuries during chamber operations, and we had to be able to treat those things. And this is, very quickly, I'll try to go through here. We may just forward fast through it so we have plenty of time for the last speaker to give her talk. And that's just showing the chamber facility itself. You can see it's a very complex set of apparatus, and this is the control room that's used to monitor the crew while they're in the chamber. And that's our tele-instrumentation pack there. You can see from the control room, and that's what we use to communicate to a workstation outside the chamber where the flight surgeons were located. And so you can see here we're at the workstation now, and we're seeing the images that the crew members are giving us during their operation. So this is the telemedicine instrumentation pack. So everything you need to do, almost full bore diagnosis, is contained within this one unit. You can see here there's a flat panel display for the crew members to see what they're imaging. There's a camera system to give skin images, and you can see the crew members are looking at their forearms to look at the skin testing that was done. And in addition, we have a retinoscope to look at the eye. We have otoscopes to look in the ears. We have other cameras to look in the mouth and nose. We have a stethoscope to listen to the heart. All of these things are contained in the instrumentation pack. We used it here in the Lunar Mars Life Support Test Program, and we subsequently used it on board the shuttle to demonstrate the technologies. And so this is These are the images that the flight surgeon is getting from his workstation, looking at the crew members. And this is the remote camera in the control room showing that operation going on. And so this is the images that we're seeing. You can see they're very good quality, and we were able to use that to make diagnosis. Just real quickly, I'll show you some of the other studies that we saw as a result of being out in the workstation. Just looking at the retina. Let's see here, I'll show you something that might be interesting to you. That's the eardrum. That's what the eardrum looks like. This is the drum itself, and these are the bones behind. We had a little bit of interference, which we had to work on. I guess that was the end of that. Sorry. I'm sorry, you had a question?
Were those non-medical people?
Exactly. These crew members were non-medical people. We did a little bit of training beforehand to show them how to work the equipment, and then we were able to guide them step by step through the examination process to give us the kind of information we needed to make diagnosis. Anyway, there's a little later shot of an injury one of the crew members had. We had to guide them through suturing that cut up, because they were stuck in there for 90 days. They couldn't come out, and so we had to guide them through that. And like you say, non-medical people, which turns out to be the case often during shuttle flights. We have non-medical, what we call crew medical officers, that are trained somewhat like EMTs or paramedics to do a lot of these things, but they're not really physicians, and so we had to do a lot of guidance from the ground. We hope that on the Mars mission we'll have a doc going with.
That was my next question.
But we'll have to support remote ops.
Well, and in that vein, did you do anything with time delays or communication?
Yeah, we actually had the time delay, not in this study, but in the ones in the aircraft, like we would have on board the shuttle. And even though it's only a little more than a second, it can be very disturbing to somebody trying to do real-time operations. When you're talking about going to Mars, the time delays can be as long as 20, 30 minutes. And so you can't do real-time support in that case. You'll have to do store and forward, the delay. You know, we can help you make a diagnosis with this image that you've given us, and this is what you need to do. But in terms of real-time support, that's why we probably need a doc to go when we're talking about the Mars mission.
Jeff, I'm going to suggest that we have the last speaker speak
Yes,
at scheduled
sure.
time. And why don't you stay here, and if you want to talk to her after she's
Okay,
finished,
sure.
you can show some more film or whatever.
Sure. That's good. All right, thank you for your attention. Just want to show you one slide here. This is where we want to go to. You can see that this sort of capability is what we really need to support Mars, telerobotics in terms of medical treatment and medical diagnosis. And so this is what we hope to have by the time 2010 to 2018 time frame to support medical ops.
Is the Army already piloting that? I've seen like
Both
things on TV.
Both the Army and the Navy have telemedicine capabilities and store and forward imaging systems. The Navy has, because they're out at sea and they have these big carrier deployments, and they don't have the ability to get people quickly from the carrier out in the middle of the Pacific to a medical port. So they have a lot of telemedicine capability now on board the carrier by this fleet medical officer. And the Army is doing it for rural, like Bosnia type situation, where their troops are deployed out in areas that are remotely located to provide on-site medical care through their enlisted folks when they can't get physicians out to those areas. So yeah, indeed, the DoD is also working on sort of technology.
Is this basically the same setup that's going to be used on the ISDC?
In terms of, yeah, the HDI 5000 ultrasound unit is going to fly in what's called the Human Research Facility rack. They're going to have a rack that's going to go into the lab module that will be for doing research on humans. Now, in addition, we're developing diagnostic clinical capabilities that we have an MOU between what's called CHEX hardware and HRF hardware. CHEX hardware is for crew health support, and that hardware it overlaps some of the research hardware, so we have an MOU that said we can share this hardware. Some of it will be used for operational medical support, some of which we use to advance our state of medical knowledge to support microgravity operations. So that's indeed what we will use, and we hope to fly some of these endoscopes that we used for this study that I described, and we're getting, trying to get mechanisms for that sort of medical onboard support as well. But the primary medical hardware includes anything from, we have a defibrillator that's going to fly, we have portable blood analyzers for oxygen, for chemistries, these types of things. We have systems to evaluate the water for contaminants and the air for contaminants, for especially combustion products that might be produced as a result of an onboard fire like we had on the Mir, or toxic release of off-gas materials. And so we're developing the capability to monitor all those things and respond accordingly based on what the diagnostic equipment shows us. And we hope to have a telemedicine instrumentation pack like I showed as part of our onboard supply, but that's not going up early. That'll be going on later, closer towards assembly complete. The first few phases are all construction phases, and we're just trying to support the ops as best we can. And missions vary anywhere from like 3 months as long as 6 months for the first ISS cruise. So we need to support them just like we would what we did for the phase 1. And we're working very closely with our Russian colleagues who have a lot of experience with support crews for long duration. And we have a whole medical operational panel that includes all the international partners that will be flying: Japanese, the Europeans, Brazilians, the Russians, and ourselves. So, very
I've
key.
seen photos of the surgical health station. That's, I think, crew habitation module, but that's much later on.
Right,
It
and
sort of looks like this, but didn't quite look like this one. But it had the table and the wall. But up until that time, it's just these portable kits.
right, until that time. And we're not sure yet which habitation module is going to fly. I don't know if you've heard, we've been working at JSC on what's called a TransHab, which is an inflatable unit we think would be excellent for going to Mars with.
Is that canceled?
Cancel that though.
Right, well, it has not been canceled yet, but there's a committee action, Sensenbrenner et al., and this is all politics, and you guys may have to be able to influence this. Basically, the contractor, Boeing, who is scheduled to build the original, has lobbied to say, we want to build the one we had planned, and we don't want a competitor in here, and they're the ones that are driving this, because this is a key technology for us to develop it. Anything
Well,
that
it's much less expensive, isn't it, the inflatable potential?
what's that?
The inflatable is much less expensive.
Well, potentially, it's certainly less expensive to up-mass, the launch characteristics
It's
are.
also bigger.
And it will be much bigger and have a lot more
Takes care of
capabilities.
the heat problem with the exercise, because the exercise area is much larger.
Right, and also, it actually has better micrometeor protection than do the hard modules.
Really?
And it would be so much easier for stowage to go to Mars and then deploy on the surface. And so it's a very important technology. And so anybody that's not affiliated with NASA, and because we're immediately considered biased being at JSC, but anybody that's not, I would recommend writing your congressman and saying that this is the kind of technology you want to see developed, and you don't like this motion to kill the project. It's too important technology.
I just didn't understand that, I mean, reading about it, I just didn't understand the background once I was killing it, so it's just, it's all Boeing
politics.
behind this.
It's all politics and
It
money.
threatens an existing program that's competing against it.
Right.
And of course, the short-term goal, but unfortunately, that is a short-term goal that the existing module, TransHab, has applications far beyond ISS.
Right.
And we know how to build, fixed modules already. That's not going to help our technology develop.
It just delays that part of the program. I didn't know that medicals was being considered for TransHab.
Yeah, in fact, we had a lot of design considerations in that for our exercise equipment to maintain our countermeasures program. We're planning on putting the crew sleep stations inside the water stowage area to protect them from radiation. There's a whole lot of things that we need to have the TransHab for crew health considerations. And all of this is in jeopardy if they cancel the program. And so anybody, like I said, not affiliated with JSC could help us politically by writing their congressman and saying that this is the kind of thing we'd love to see developed.
Yeah, that was kind of a shock.
Yeah.
I was surprised too. Are the different nations, is there going to be one medical protocol followed, or are they, each nation, going to be kind of have their own medical kits?
They're not going to have their own medical kits. The onboard care will be integrated. a very important concept. However, when it comes to pre and post-flight care, each country will be responsible for that. So we've agreed as partners to have an integrated program for in-flight care. It'll be all be integrated through JSC for Mission Control Center in Houston. But for pre and post-flight, we're going to let each program manage their astronauts and develop rehab programs and conditioning programs prior to flight. And then we'll all have a standard set of testing that will be done pre and post-flight, so we can at least evaluate what their health was going in and what it was at the end of their mission. And so we've agreed upon those things. So in terms of the in-flight care, it's all going to be integrated together.
So whatever meds and equipment are flown by JSC, that's what they have to be used. And I know there are differences, like in the Russian program, when they use things that are not available here. And
Right, but we've agreed upon some common medical supplies, and there are some Russian supplies, and their crew members will use it probably more than ours. We'll give them to their crew members more than we'll give to our own astronauts, because we have our own kit that we use. However, that'll all be coordinated through JSC, and so the flight surgeon, there will be one crew surgeon responsible for that crew, usually a three-person crew early on, and for the most part, that is going to be an American flight surgeon. Now, later on, there is some potential, as the program matures, to have other international flight surgeons be the prime crew surgeon, but only after they meet all our rigid training requirements. So, at least early on, the Americans will be pretty much in control of the medical operations, but it's all integrated. We're working together. Cool. Great. All right.